Hello, Brazilian cardiologists. I'm very happy to be joined today by Dr. Robert Bonow, who is from Northwestern University of Chicago. And today we just saw the result of the partner trial. That is one of the most important trials in the field of valvular heart disease, and maybe one of the biggest steps on cardiovascular medicine. Dr. Bonow, I know that you really likes valvular heart disease. Can you just summarize to Brazilian cardiologists what are the main results of the partner cohort A trial?
This is the first randomized prospective trial comparing surgical aortic valve replacement with catheter-based or transcatheter aortic valve replacement. All of these devices are approved in Europe, and we saw the earlier results of the partner B trial, which was comparing the catheter-based aortic valve replacement versus no treatment. This is a head-to-head comparison with surgical results, and the outcome at 1 year was shown to be non-inferior to the surgical approach in terms of cardiovascular mortality. So it's a very exciting result, with some caveats that we need to keep in mind as we follow this field forward in greater detail.
In terms of the safety endpoints, we saw that the patients in the TAVI group, they had more major strokes and TIA, and also major vascular complication. But instead, they have less major bleeding and less new AFib, recent onset. But I think one thing it's important because about the paravalvular regurgitation. How do you think this could impact the clinical symptoms for the patient?
Good point. That one of the other findings that there's more aortic regurgitation following the transcatheter approach is paravalvular. It tends to get better with time in many patients, so it's usually not severe, but certainly in some patients, when it's severe, that could cause some problems because you have, in a patient with aortic stenosis, a small hypertrophied left ventricle. It's not designed to handle a sudden increase in volume. So the volume load in some patients could be difficult, and in fact we see this. It needs to be treated with therapies to reduce afterload and diuretics and so forth to reduce volume. But in most patients it tends to get better with time, and does not appear to be a major problem, although it is higher likelihood of this with the transcatheter aortic valve replacement than with surgery.
And in your patient, what is the maybe, if we know, the best antiplatelet therapy, the regimen, and for how long can we keep with it?
Very good question. I'm not sure we know the answer. We do tend to give dual antiplatelet therapy for a short period of time, but not for a long period of time. And I think we need to have more information as to whether the mechanism for the stroke is related to endothelialization of the stent structures, or is it more related to the vascular damage that occurs as this relatively bulky delivery system goes across the transverse aorta and the ascending aorta. So the mechanism for the strokes is not clear, and that needs a little bit further work. It may be that stronger antiplatelet therapy after TAVI may reduce the strokes, but that's probably another trial that needs to be done to answer that question.
Or maybe one day we can use warfarin instead of just the antiplatelet therapy. And we just see today also a very interesting result of the cost effectiveness results in that patients unsuitable candidate for surgical aortic valve replacement. So you think this is a real important question to the daily clinical practice?
Not so much from the clinical practice, but I think one of the concerns would be that if the clinical results are the same at 1 year in terms of survival, then we need to look at quality of life and also cost effectiveness. And if it's much more expensive than surgery, that could cause a problem in my system and perhaps also in your system. The cost analysis was not done comparing surgical AVR versus transcatheter AVR. The the economic analysis was based on partner B, which was what is the cost in performing TAVI versus performing medical therapy, and it did show that there's a high cost of TAVI compared to medical therapy, even though those patients without TAVI tend to have many hospitalizations, which do lead to more costs. The costs are still higher with TAVI. What we need is a comparison of surgical AVR compared to transcatheter AVR from a cost analysis, because at least in the US, the hospital costs for doing surgical aortic valve replacement appear to be less, substantially less, than what the transcatheter device would cost.
But now that we have at least as good as alternative to AVR, the TAVI, how can we decide with our clinical practice which patient we're gonna send to AVR and which patients we're gonna send to TAVI?
I don't know the answer to the question. Clearly, most patients would rather have TAVI, and my patients are already asking about this. Even the patients who are low risk, straightforward candidates for surgery, they're aware of this technology. Many of them are asking about this. Patients who need surgery are saying, I don't want my surgery now, I will wait until this device is ready for me, and that may be decades from now. And so even what we do know is in the higher risk patients, if they're still candidates for surgery, that's still a good option. The surgical results in partner A were terrific. They came in with a much lower 30-day mortality than predicted. The outcomes were great. It was, I think, a highlight of the trial from my perspective was how well the patients did on the surgery arm, even though they were such high-risk patients. So I don't know how to address the individual decision-making we have to make, weighing the risks of the hemorrhage and atrial fibrillation on the one hand versus vascular damage and stroke on the other. It's a discussion we have to have with the patients. And of course, in my country, these are not yet approved devices.
And one last question: can we see in the future with the much smaller device with better results that maybe will expand the indications to treat patients with critical aortic stenosis, but asymptomatic patients?
Well, perhaps. Again, we need to see how the threshold is reduced with time. The next step would be to look at patients who require aortic valve replacement because of the standard indications, mostly symptoms, but are low risk for surgery, and show that TAVI has the kind of durability that we need. That's what we don't know yet, is how durable this valve would be, where we do know that with surgery. Moving to the asymptomatic patient is still, I think, a long way away until we have more data regarding durability.
Dr. Bonow, thank you very much for your attention.
Thank you very much.